course of Keratoplasty Masterclass, and we have Dr. Rajesh Fogla speaking on deep anti-lamellar keratoplasty. And Dr. Rajesh is a well-known ophthalmologist in India and across the world. And sir has done a great work on DALK, and he has changed the way we are attempting dark nowadays. Dr. Rajesh.
Yeah, good morning. Thankful to the three people who have, got up in the morning. So early bird catches the worm, so you will get to know the tips. The topic is big bubble versus manual DALK, no financial interest. The biggest advantage of doing a DALK is that you preserve the host endothelium, thereby you reduce the risk of endothelial rejection. So the long-term survival of the graft is far better. Basically, two type of techniques we do. One where we expose the pre-decimus layer. Earlier we used to think that that's the decimus membrane. And you do a manual dissection to reach the near decimus level within 100 microns of it. You can inject air or viscoelastic in the stroma to create the plane of separation. And preoperatively, I think the two most important investigation that you should know is one, the regional pachymetry. What's the thickness across the cornea, so you can decide what size of trephine you're going to use, especially in ectatic disorders. And you do a corneal anterior segment OCT, in which you can see whether the pathology is involving the decimus layer or it's located in the anterior 80 to 90%. If the decimus membrane is not involved, then you can think about doing a big bubble technique, or otherwise you have to go for the manual technique. Professor Dua described the pre-decimus layer, or the Dua's layer, which is basically a surgical layer where when we inject air into the stroma, you get a type 1 bubble, which is a separation between the stroma and the pre-decimus layer. The bubble starts in the center, goes to the periphery. A type 2 bubble is actually a separation between the pre-decimus layer and the decimus membrane. It doesn't have a dense white margin. It has a very sharp margin, and it can start from the periphery and go across the entire cornea. And you get a mix of the type 1 and type 2 as well, which starts as a type 1 and then breaks into a type 2. Among the indications, yes, you can do it for anything where any condition where the endothelium is healthy. Commonly, we do it for ectatic disorders or corneal scars and dystrophies. If you have macular dystrophy, very advanced keratoconus, extreme thinning and scars involving the decimus, you would prefer to do a manual DALK. Also, a failed big bubble, or you get an abnormal response to the air injection. Sometimes you have microperforation during the surgery. Then you can also convert to a manual DALK technique. So it's important that you learn both the techniques and be familiar with that. For either of the technique, a partial thickness trephination is essential. Commonly, we use the Hesberg pattern suction trephine, where a quarter turn of the trephine cuts down a depth of 60 microns. You have these guarded depth trephines of 300, 350, or 400 micron blades, where manually you can trefine and reach up to that depth. You can do that with a femtosecond laser, or in certain cases, you can even use a preset diamond knife set to the desired depth and achieve that trephination. For a manual technique, we basically, after trephination, we debulk the anterior half of the cornea. The other video is of a failed big bubble. So you make this peripheral pocket at the base of the trephination at about 85-90% depth. And then the pocket is carried along the edge of the trephination. So it's basically creating a stromal pocket both clockwise and anti-clockwise. And this is ideally at a depth of about 85-90 microns. And then you can start peeling off the stroma. So basically this technique is a modified Malbrun's peeling technique. If you feel that by applying the pressure you're able to peel relatively easily, then you know that you're very close to the decimus membrane, because the stromal fibers are much more loosely attached in the posterior half of the cornea. That's some of the clinical cases, a case of hydrops with a posterior scar where manual DALK has been performed. You can see that the residual bed is only about 30 microns. If you can switch off those lights, I can talk better and maybe they can see the slides better. This is another case where a manual DALK is performed, and you can see that the outcome looks pretty good. If you have access to intraop OCT in real time, you can see the amount of residual stroma that's left behind, and that's pretty useful, especially when you are performing a manual DALK surgery. This is a nice paper from Paulorama back in 2013, where in a large series of 288 eyes, they performed a manual DALK in all their cases, and the rate of perforation was pretty low, only about 4.2%. Induced astigmatism was also low, especially in lamellar keratoplasty, because you're not opening up the anterior chamber. The amount of induced astigmatism is usually less, and the majority of the patient had about 20/40 or better. For a big bubble DALK, we do the trephination. I like to debulk the anterior half of the cornea, and then we go ahead with the cannula, which is placed at about 80–85% depth. You inject air, and you get this whitening of the cornea and this appearance of the big bubble, which is has a dense white frothy margin, starts from the center and expands to the periphery to a diameter of about 8.5. You will feel an initial resistance, then a giveaway sensation, and then as the bubble expands, the resistance builds up again. I like to do a sequential air injection where the initial air injection is performed, following which, if you don't do a parasent, if you don't release the pressure, the aqueous doesn't get displaced, and you can have a rupture of the type 1 bubble. So instead of that, we initiate the bubble, and then we do a paracentesis to release the aqueous so the counter pressure is minimized, and then you go ahead and expand the bubble to the desired thickness. You get the big bubble identified by putting a small air bubble, or you intraop OCT, you can see directly the big bubble, or you can see that the periphery becomes soft after releasing fluid from the paracentesis, but the center part where there is a bubble, it will remain firm. To deflate, you can put some viscoelastic on the cornea, and then you can use a knife to just go ahead and release the air. The presence of viscoelastic retards the egress of air, thereby you get a gradual collapse of the big bubble and not a sudden collapse. You can excise the residual stroma by dividing into segments. But remember, if there are peripheral adhesions, release them. If you don't do that, when you're excising the stroma, you can end up with a perforation as well. The donor diameter can be the same size for ectatic disorders. And if you're doing it for other indications, I usually oversize by 0.25. Postoperatively, you don't need to use steroids pretty long. You can use it for the first 6 weeks and then move on to softer steroids. The endothelial cell counts are preserved, so definitely the risk of rejection is much lower. Femtosecond laser give you the shaped incision, so the induced astigmatism, while the sutures are there, is much less. But sometimes when you remove sutures, you can still have unpredictable astigmatism even in these eyes. These kind of scenarios where this is a perforated ulcer where glue and amniotic membrane has been done, we were referred for a corneal transplant. We went ahead and decided to do obviously you can't do a big bubble technique in this case, so we decided to do a manual DALK starting from the opposite end, and then you do your manual dissection after reaching 85–90% of the depth. And as you reach the last part, the perforation, you have to do a little bit of sharp dissection as well. And you can see that's how it looks in the immediate post-op, and at 1 month you can see that the cornea looks pretty clear with good cell count, about 2,800. It's a young patient and a corrected vision of 20/30. Post-operatively, both the big bubble or the manual DALK, if you have a perforation, there's always a risk of double anterior chamber. So surgically, intraoperatively, you can make a small inferior PI and then do a complete air fill. Or if you see this post-operatively, you can go ahead and do a rebubbling. Remember to keep the pupil dilated to prevent a pupillary block, and that's very important. So this is a flow chart just to show you the decision making for the DALK surgery, whether you do a big bubble or a manual DALK. So it depends on the scars, whether they are involving the decimus or the predecimus layer, and the response to the air injection, whether you achieve a bubble or you don't achieve. So then you can go ahead and do a manual DALK. So in conclusion, DALK should be considered as a procedure of choice for corneal disorders with healthy endothelium. The pre-op evaluation and surgical planning is essential to perform either a big bubble DALK or a manual DALK and minimize the intra-op complications. So if you go ahead and try to do a big bubble DALK in every case, you're more likely to encounter abnormal responses to the air injection. And the bearing of the predecimus layer is not essential for a successful DALK, but try to go as near decimates as possible. But the other thing is to leave behind a very smooth interface and not an irregular interface. You may have to fashion your corneal grafts depending on the size of the bed that you have. If you're doing a manual DALK and you have a bed of 100 microns, don't put a full thickness graft. You can always go ahead, prepare a 400 micron graft, and then put it in place. And in future, the femtosecond laser technology and the intra-op OCT definitely will help improve further outcomes. Thank you. Thank you for your patient hearing.
Thank you, sir, for the wonderful talk, wonderful CPs, and those videos. I just want to ask one thing. Recently, I did a DALK and I got a type 1 bubble and multiple pockets of type 2 bubble. So, what I did is I went out with type 1 bubble and left those small bubbles, expecting that they will resolve in post-op. But for next till 1 week, those bubbles were still persisting. Have you ever encountered such
Yes,
situation?
that's sometimes we get these mixed bubbles where it starts as a type 1 and you also get a type 2 as well. If the type 2 bubble is very small, if you just leave it, it will spontaneously absorb. Otherwise, if there's a large bubble, I'm more worried about the endothelium touching continuously being in contact with the iris. So in that scenario, I will open up the type 1 bubble, complete my rest of the surgery using manual dissection. But before I put in my graft, maybe I'll use a knife and just make a small nick to release the air from the type 2 bubble, and then I can put in my graft.
Thank you, sir. Any questions?
Correct.
So, have you noticed any difference in outcome between type 1 and type 2 bubble in terms of visual acuity?
No, type 2 bubble, if you try to expose it, which we have done, sometimes in macular dystrophy, normally
Yeah.
when you do that, you do get the type 2 bubble quite frequently. But the problem with type 2 bubble is, unlike the pre-decimus layer, which is quite resilient, the actual decimus is very fragile and you can break it. So you have to be very careful. You have to keep releasing aqueous, counter pressure has to be minimized. And the other problem is post-operatively, the incidence of double anterior chamber, even if you don't have a perforation, in that scenario can be a little high. So you have to be prepared for that as well. But if you do a good manual dissection, you can still get good outcomes, but the recovery may take a little longer. Unlike a big bubble DALK where at 1 month your patient can see pretty well. If you do a manual dissection with a near decimus dissection manual, at 1 month they may be about 618, but for them to reach 6966, it may take 3 to 6 months. And also it depends on what kind of graft you have put. I've realized that previously when in that scenario we were putting in full thickness graft, during surgery you will be able to oppose the graft and the host. But when you remove the sutures, you find the graft becomes a little elevated. Yeah. And if you see on the topography, you will see a ring of steepening at the graft host junction with the relative central flattening that somehow induces aorta aberrations and your patients are not able to see well. So I follow now what Massimo Busin does is I always take a microkeratome with a 400 head. I prepare my anterior graft of 400 micron thickness, and I find that my apposition is much better, and the post-operative shape of the cornea also looks pretty good.
Just one more question, sir. In macular dystrophy, especially at RP center, the patient profile that we get, you are scared of doing PKP, full thickness graft. But nowadays, I think this is a general consensus in all macular dystrophy. You should go ahead and do a PKP rather than DALK. So, what's your take on that?
It depends on the extent of involvement and the age of the patient. If you have a patient who's 25, 30-year-old with macular dystrophy, maybe, and it's not too dense, I will still try to do a DALK. But if I have somebody over the age of 45, 50 with a macular dystrophy, I will do a triple PK. Because I've realized that in such cases, even if I successfully do a DALK, the visual outcome is not optimal because you will find that even the pre-decimus layer will have the deposits, and somehow when the patients come back, and we know that macular dystrophy is also associated with poor endothelial cell count. They have a lot of guttate changes. So instead of making it a double procedure, I think doing a good penetrating keratoplasty gives you reasonably good outcomes.
Thank you, sir.
Thank you
so much. And next talk will be by Professor Rajesh Sinha, and sir will be speaking on anterior lamellar keratoplasty. Thank you, sir. Sure, thank you.
Thank you, Dr. BHUPESH, for the opportunity. Uh, I'll be talking about anterior laminar keratoplasty, traveling the correct depth. Well, when you are thinking about the depth of anterior laminar keratoplasty, it depends on the depth of involvement of the cornea. Say, if it's a very superficial opacity, you can just manage by PTK, just remove the epithelium and use excimer laser to ablate the stroma. So something about 75 to 100 microns you can manage. And if the corneal thickness is good, it will maintain clarity as well as maintain the topography of the cornea. And this is how it looks like pre-op and post-op, and Reese-Buckler dystrophy, pre-op, post-op, a case of a post-pterygium involving the visual axis. After removing the pterygium, there was some significant haze, so PTK was done. It improves clarity. But if the opacity goes deeper down, earlier, even in granular dystrophy, I still remember maybe 15 years back, we still used to do a PTK, and we just thought that maybe a little bit of opacity here and there the patient will manage. But these days we have a better option for that, because in granular dystrophy, in any case, it will involve at least 200 microns. And in such a case, you can do a sutureless superficial anterior laminar keratoplasty. So you create a donor lenticule of same thickness as you will be dissecting in the host. And then in the host, again, you use a microkeratome to remove the tissue. Remember, whenever there's a nodule or etc., then you should remove it manually. Otherwise, there will be the shape of the bed after creation with the microkeratome cut will not be regular. So once you remove it, you can see it has cleared up. And then if there's a cataract, then you can do a cataract surgery and then put a donor lenticule and dry the edges, and then put fibrin glue at the edges and put a bandage contact lens. This is how it looks like in the case of a granular dystrophy. Preoperative, I showed you. This is the postoperative picture of the same patient. Looks quite clear, and the patient has reasonably good visual outcome. Some patients, I have noticed that there is some astigmatism, and perhaps the reason is this, that when you're putting the donor tissue, there is some configuration of the donor tissue as well, and that is the reason for some degree of astigmatism, but the visual axis is quite clear. The one problem that when you're doing a microkeratome salc, in the periphery, there can be some epithelial ingrowth, or there can be glue that can enter into the peripheral part of the tissue. So if you are doing a femtosecond assisted anterior laminar keratoplasty or FALC, then in that case, it's a case of a healed keratitis, wherein you can see it's vascularized as well. So with the help of femtosecond laser, the dissection, sometimes you have to do a little bit, takes some time, but it clears up nicely, and you can clear up. You can see here, this is the case of a healed keratitis wherein femtosecond laser has been used. So once you remove the tissue, you can replace it with a donor lenticule. If there's any irregularity, you can smoothen it with the help of a diamond burr as well, and that will work. But don't do excessive use of diamond burr, otherwise it can cause haze. And then you place a donor lenticule, and that works well. The biggest advantage of femtosecond laser is the apposition, edge-to-edge apposition. You can see this is the case of a FALC. The edge-to-edge apposition is perfect in this, because you have a vertical edge with a femtosecond laser, and that is the advantage of FALC over SALC, which is microkeratome assisted. If the opacity is deeper down, like this case, you can something beyond 200 microns, you cannot leave it sutureless. So you can do a automated laminar keratoplasty or a manual keratoplasty. So the idea is to reduce the density of the opacity, and then you can put a donor tissue. The advantage of automated keratoplasty is a good interface, and that's how the quality of vision is good. Deep anterior laminar keratoplasty is for for diseases which involve up to the stroma, and as was discussed just now, it can be done by layer dissection as well as big bubble. The big bubble technique is the preferred technique, wherein you can create, this is a type 1 bubble which has been created. So as you give the brave slash, you reach that position, you inject viscoelastic, and must have been discussed in the previous presentation. So you sort of a divide and conquer technique, you remove the stromal tissue, and then you place the donor lenticule. We were just discussing about a macular dystrophy. I completely agree with what was discussed. Macular dystrophy, it depends on what is the stage and how much is the involvement of the stroma. If it is macular dystrophy, can involve from subepithelial area space to the endothelium. So if it's involving up to that extent, if it's involving up to desmase, then there's no point doing a DAL. Involving up to the desmase, it is in the stroma, you can go ahead and do a DALC. And intraoperative OCT does help, as you can see here. The moment you create a bubble, and behind, this is the bubble, and then as you give the brave slash, the desmase again goes up. Now you will inject the viscoelastic. So again, you can see the desmase is down, and then you can go on and dissect it. And so it's safe because you have a reasonable space. You can see the scissor movement, but the desmase has fallen quite back. It is quite behind. So you can go ahead and complete the procedure. Similar thing has happened in this case, as was being discussed. There was another bubble that in between the Duas layer and the desmase layer. And once you put a couple of sutures, you can just lift the donor lenticule and make a small puncture in the area where you have that bubble, and then you can go ahead and complete the procedure. So that is the end of it. Manual dissection, again, you have to do sometimes, because in cases like, say, healed hydrops of in keratoconus, you cannot do a big bubble DALC because there's risk of opening up of the posterior lamella. So in that case, you can do layer by layer dissection. But again, intraoperative OCT, microscope integrated OCT, helps you to know at what level you are working, and whether in one side of stroma you have in one area of cornea you have more stroma, and the other it is less, so you can make a uniform bed for the donor lenticule to be placed, and then you can suture it. So in conclusion, anterior lamellar keratoplasty is a very useful technique because the risk of rejection is negligible, and the only thing you have to decide is that what is the level that you have to reach. The idea is to remove the disease layer only and leave the healthy tissue in its place, so that we don't have much risk of rejection. We don't have excessive of donor tissue in it. But depending upon the involvement and depending upon the disease, we can decide and go ahead. If it's less than 200 microns, then you can leave it sutureless. If it's more than 200 microns, you have to do a sutured procedure. So thank you very much for your patient listening. Any suggestion or question, I'll be happy to answer.
Thank you, sir. Sir, I've seen you doing the diamond burr on the bed. So how you
Yes.
titrate the timing, that how much you should do, because you cannot see anything.
You cannot.
And if you do more, it will cause haze.
Yes,
So
that's what I said, that if you do more, it will cause haze. So if you see that there is some surface irregularity, because in a case of a healed keratitis, even if you do a femtosecond assisted, when you do a dissection sometimes can be irregular in the area of scar. So what happens that if there is an obvious hill and trough, then you do use a diamond burr. Otherwise, we don't. And there also you have to be very careful. Just do a little bit. If you do excessive, it will cause haze.
10 seconds maybe? Around 10 seconds or something.
Yeah, I mean, you just have to titrate, and it can vary with case to case. You cannot exactly tell that this time 10 seconds or 20 seconds, whatever you want, but you just have to titrate depending upon case to case. So it's very variable. You have to be very judicious. It can remove the irregularity, but if you do a little bit more, you can create haze as well.
Thank you, sir. As you showed that in that video, microscope integrated OCT is quite helpful, especially for manual dissection. What is your endpoint? Till what depth you would like to go for in such cases?
Which cases, which surgeries?
All these
Valve?
cases where you are doing a manual DALK
Huh.
assisted by microscope MIOCT.
Yeah. See, it depends on the pathology. Like if it's a case of a keratoconus, and I'm doing a manual dialk layer by layer, and suppose it's a heel hydrops with the scar is at the edge of the pupil, you can still go ahead and do a dialk, because as the cornea will flatten, it will go further in periphery. So there you leave a little bit of stroma. In a case of macular dystrophy, you would not like to leave any layer of stroma. So the last layer you can even hydrate and peel also when you are doing a manual dissection in a macular dystrophy. So it depends on the disease condition which you are tackling, and accordingly you have to reach the depth.
Any alternative to MIOCT somebody can use? If somebody doesn't have a MIOCT, is there
Well,
any?
there are various methods. You can inject air bubble, and then when you are using the blade, you can see the dark band which Melis used to use. That will help you an idea how much of the stroma is left. So that is also one rough idea by use of an intracameral bubble, air bubble.
Thank you, sir.
Thank you.
Good morning, everyone. So I'll be speaking on femtosecond laser assisted keratoplasties. I have no financial disclosures to make in this presentation. So it won't be wrong to call femtosecond laser as the new scalpel in ophthalmologist's hand. And with this new device, we can do cataract, LASIK, keratoplasties, and whatnot. So everywhere you will find some or other role of femtosecond laser nowadays. So femtosecond laser is basically a photodisruptive infrared laser with a power of 10 to the power minus 15, and it works on the principle of photodisruption, in which thousands of laser pulses are connected together in a raster pattern to define a resection plane, and similarly vertical planes are created. And once it got cut, then this gas is absorbed and the resection plane is created. So if we talk about manual keratoplasty, it is a time-tested, most successful organ transplant. Although the challenges are so many, like high astigmatism, the problem with the trephination, sizing, ledge, the problem in suturing, how much tension to apply on during suturing, the correct technique. There is significant endothelial cell loss in penetrating keratoplasty, high expectation from the patient, and after all these, delayed visual rehabilitation. So to overcome most of the problems, we have femtosecond laser, which gives significantly better results in terms of these points. So femtosecond laser has the ability to perform incision of any angle at various depths within the corneal tissue. It permits full thickness graft with peripheral lamellar wound configuration. You can create any shape with femtosecond laser, like top hat, mushroom, zigzag, and other configurations. So how to choose which type of shape should be done in which kind of problem? Like top hat shape, it removes less stromal tissue and more abnormal endothelial tissue. So it will be a good shape for the PBK cases. And mushroom shape removes more abnormal stromal tissue and save more endothelial tissue. So keratoconus will be a good choice for this shape. And in the zigzag, it provides excellent wound seal, because the angled edge provides a smooth transition between the host and donor. So the opposition is good, so can be tried in any cases. So if we compare the image of OCT at 1 week between the manual and femto, you can see the graft and donor. It's attached very nicely because of this configuration cut. But in the manual, the edges are usually bunched up in the initial post-op period. So now we have different platforms which provide the opportunity to do femtosecond laser, like intralace, LDV, and wavelight. So this is the video of femtosecond keratoplasty done in a case of corneal scar. So with the newer machines, you can play with the energy, increase the energy, so you can cut the corneal scars also. In the old machines, it's difficult to cut the scars, but with the new machine, you can cut it. So once the patient's cornea is cut, now this is a donor. It's better to remove the epithelium to have a better docking. And this is a femto LDV Z8 machine which I am working on. And this has intraoperative OCT in which you can see how much you're going to cut, what shape you're going to get. And just simply you have to peel it off. No tissue bridges. And this was a complicated case and went very well. You can see the cut area, it nicely fit, the donor and host nicely fit with each other. So this is another case of keratoconus. Again, you can shape the pattern cut here. The advantage with the femtosecond laser is that suture strength need not to be very tight. It has to be normal strength sutures. The length of the suture is slightly smaller than manual keratoplasty because you don't need so much of tension in the sutures. And chances of overriding or underriding is not possible with the pattern cut. You can see the opposition there. It nicely fits. So this is a post-op picture. So suturing, conventionally we do 16 sutures in most of the cases, but with femtosecond laser, I prefer to do 12 sutures. Although I've tried 8 sutures with fibrin adhesive, but I still recommend 12 sutures sufficient with a femtosecond penetrating keratoplasty. And sir has already covered the role of femtosecond laser in lamellar keratoplasties. Many cases you cannot do with the microkeratome because you cannot measure the exact depth, how much you're going to cut. But with the intraoperative OCT and femtosecond laser, you can customize your cut and get the exact plane in which you need to be cut. So this is another interesting case of post-smile lenticular retention. You can see the scarring there. And this patient came to me and I took this patient for this hemi-automated lamellar keratoplasty. So with the femtosecond laser, you can design the cut pattern also. So I made a donut-shaped cut in this case. So you can see there is a cut all around the scar. The scar was very dense, so it was cut here, and we get a resection plane all around in the same plane. After that, you can combine it with the manual procedure because the plane is same all around. So you'll go in a one plane only. It won't be a multiplanar. And this is a donor. While lifting, we have to be very careful. Sometimes tissue bridges are there, so we need to manually separate those. And once it is done, then the suturing. Suturing is done, and this is a post-operative picture. You can see the scar has gone. The position is very nice, and the result was good. And with the Zimmer machine has a software for DALK. So as a cornea surgeon, we all know that in DLK, the main problem is to achieve the big bubble. You're not sure whether you're going to get big bubble or not. It's always unpredictable. So with this software, you can create a tunnel also in the posterior stroma, and you can decide the width of the tunnel, the length of the tunnel, the angulation, the position where you're comfortable, and you have to leave around 30 microns behind to push the air. And once you create the tunnel, everything on the OCT, so you're sure that where is your tunnel is, how long is your tunnel, and then go with and this is a separation, removal of stromal tissue, and this is the tunnel you can see here. And then go with the Foglas cannula and inject air. So probability of getting air bubble is quite high. The big bubble is quite high with this software. And then rest of the step is similar. So femtosecond is also helping us doing the DLK now. And this is one procedure which you cannot do with manual keratoplasty only. This is a lenticular insertion in cases of advanced keratoconus, because you cannot create a pocket with any manual device. So you have to use femtosecond laser. So for thinner corneas like 320 microns, 330 microns, you can create a pocket here and then open up the pockets. And then this is a lenticule of another patient of known thickness, and you just push, you have to push the lenticule in the pocket. Make sure that the lenticule is nicely sitting in the pocket, not in a wound. And once you secure the lenticule, the job is done. So very simple procedure. You know at what depth you are putting the lenticule. The procedure is quite simple, and then remove the epithelium. Go for epi of cross-linking to get the good result of cross-linking also. So no need to go for hypotonic or epi on cross-linking. With this lenticule, you can do the procedure. So in conclusion, femtosecond laser gave new dimension to keratoplasty techniques. Early visual rehabilitation, less astigmatism, ease of doing surgeries are the main benefits of femtosecond keratoplasty. Thank you so much. Thank you.
Thank you, Bhupesh. Since you are doing this femto-assisted PKB since a long time, so what is the proportion of cases in your practice that you prefer femto PKP?
So,
And what are the factors that
yeah.
really discourages the patient to go for a femto PKP?
So my first choice for all optical keratoplasties are femto only. As a private practitioner, I always offer femtosecond laser option. So in cases of very dense scar or repeat graft or vascularization, I sometimes offer the manual keratoplasty also. Or the main indication for manual is the financial grounds, because many patients cannot afford, because this charge 50,000 more than the manual keratoplasty. So my choice is femto for all the cases, all optical cases. Go for femto. Yeah.
What about the interface if you do a microkeratome assisted anterior laminar keratoplasty and the femto assisted? Like in some of the platforms, if you go deeper, the plane is not regular.
Yeah. So with this machine, this has you can change the energy interoperatively. So there is a nomogram. If there is a mild scar, you can change the nomogram, increase the energy. Cut is very smooth, because they are doing DSEC also. They are starting DSEC surgery also with the femtosecond laser. So there is no problem of the unevenness of the bed. So we can go for
And the tunnel that you showed, what is the maximum length of tunnel, diameter of tunnel that you can create?
I don't remember. There is a nomogram with the can. If you have a 24 gauge, 27 gauge, accordingly, there is a nomogram from the company. You just feed those nomograms and you can get the tunnel length.
Okay. Do you remember any vaguely that what was the size? It's difficult.
Sorry,
Okay.
don't remember. I have that nomogram. I can send it to you, sir. But it is a nice thing. You are sure that you're going to get big bubble, because initially we were not very confident that we'll get a bubble or not bubble. Then we just counsel the patient that we'll do DAL or PK. We'll see on the table. But with this, I'm pretty confident that we are going to get big bubble. So that is the best part. So yeah.
Thank you.
Thank
Thank
you
you,
so
Dr.
much.
Bhupesh.
Thank you.
And now we move on to Dr. Praful Maharana, who will be talking on PK,
DSEC.
DSEC.
So good morning, delegates. And so I'll be speaking on this topic, DSEC and its significance in the era of DMEC. So why this talk? Because wherever you go nowadays, you see a lot of talk about DMEC, and few decades back, I think PKP was replaced by DSEC, and now for corneal endothelial disorder, is the DMEC is the procedure of choice. But there are few situations where you may have to go for a DSEC. So if you look at this table, so this is where I have highlighted which are the advantages of DSEC over DMEC. Visual outcome wise, both are almost at par, but DMEC is better because a large proportion of patients they get 20/20 vision. Learning curve is definitely easier with DSEC. Amount of manipulation of tissue. So this point is not for those surgeons who have done more than 1000 DMECs, but for surgeons like me who have done hardly 50-60 DMEC. Now the manipulation of tissue that is being done for graft attachment significantly more in DMEC compared to DSEC, and that may translate into your early endothelial loss in cases of DMEC. Post-operative graft detachment, even with experience, and this can be a problem, and it is definitely more than the DSEC. Endothelial loss, again, If you are expert enough, then DMEC, the endothelial count may be as good as DSEC, but for less experienced surgeon, definitely DSEC is better. Final visual acuity is definitely better with DMEC. And donor age, this is an important part for Indian surgeons. Why? Because we get a lot of tissue of optical grade of 15-year, 20-year age, and those tissues are really tough to use for DMEC. But you can use those good quality tissue for DSEC patients. So these are the advantages of DSEC that you can get over DMEC. Now I'll go through a few case scenarios where I had to do a DSEC instead of DMEC, and there I'll highlight the special situation where DMEC is useful. This was a case of ACIOL with corneal decompensation. As you can see, the haptic are visible here. It was a huge IOL and it was impinging on the angle. So first I did the epithelial debridement, and as a routine I prefer corneoscleral tunnel incision for my DSEC cases. So this was the corneoscleral tunnel that I prefer. Um, and this was a haptic, so it was a big aisle. I had to cut it and remove it. So before removing the aisle, the routine steps of DSEC like decimal scoring is done. Now since I am not bothered about the endothelium, so I can go in and cut the aisle into two halves and then try to remove it. So this is the first half. As I am trying to remove the aisle, you can see a lot of vitreous blob is coming out. So whenever this vitreous in entry chamber, doing a DMEC is difficult. Why? Because the vitreous stand may not allow your graft to unroll comfortably. So that is a problem. So we put an adequate size Kelman multiplex ACIOL and we went out with a DSEC. Again with ACIOL in situ, doing DMEC will be a great challenge. So for such cases, it's better to use DSEC. This is the standard technique that I prefer, bimanual technique of graft insertion using Bucin glide. And as you can see at the end, it was a nicely placed and graft was well attached. So such cases it's better to go for DMEC compared to DSEC. This is a graft representation I am showing you because in Western countries you get a pre-peeled DM roll, but in India most of the time is the surgeon who has to prepare the roll. And if you don't have that expertise, you may lose some of your tissues. But in DSEC it's not a problem. If you have an automated microkeratome, it's all automated procedure. You just need to press the foot switch and everything is done. And second, you can customize your graft. As you can see here, you can measure the thickness. If you don't have access to microscope integrated OCT, you can use even pachymetry also. So this was another case. It was a one-eyed lady, 80 plus, and she was aphakia with corneal decompensation. I didn't want to go for SFIL because there was associated glaucoma. So my plan was just to clear the cornea using a DSEC graft and give her some reasonable vision. So as you can see, I was doing decimal scoring. The cornea is little bit opaque. The visibility is not that good. So again, poor visibility is an indication where you should go ahead with DSEC instead of DMEC, because while manipulating the graft inside, you may struggle a lot. Since it was aphakia, there is definitely a risk of graft falling behind. So what I do normally in such cases, I put a stay suture. This is a 10-0 monofilament suture. So in case my graft falls back, I can pull it up with that. Then the rest of the technique is same. Using a Bucin glide, graft insertion was done. And once I am sure that okay, my graft is well attached, then I'll cut the sutures and remove those stay sutures. So in such cases, aphakia with extensive pus with glaucoma, where you don't want to take a chance, and a 80-plus-year lady where you don't want to do another procedure, in those cases it's always good to go for a DSEC rather than DMEC. This is another video. It was a case of ocular surface disease with failed graft, as you can see here. And in such cases, again, it's good to go for DSEC compared to DMEC, because I'll show you in later half of the video, you will notice there is a iris adhesion throughout the graft host junction. So in such cases, where the visibility is not good, the entry segment details are not clear, or the entry segment has a lot of issues like extensive iris synechia, in such cases, it's better to go ahead with a DSEC compared to a DMEC. As you can see here, graft attachment is centration is little bit difficult because of the graft host junction. But with experience, you learn how to bring this graft to the center. And this was the microscope integrated OCT picture. As you can see here, graft and the graft host, this is the graft host junction, and there is a clear good distance from the angles. However, if you notice here, see here, there are adhesions here, right? This is the graft host junction and the iris was stuck there. and releasing those sync and then performing a DMAC, again the DM will not unroll and centration will be an issue. So for such cases with extensive pass and Sinega, it's better to go ahead with a DSEC rather than DMAC. This is the last video. This was a case of CHED. In all these cases, the visibility is so poor, you cannot even try DMAC. In such cases, definitely DSEC should be the procedure of choice, and DSEC is quite useful and it gives excellent result. These hazy cornea, they usually clear over a period of 2 to 3 months, and at times you will be surprised how clear the cornea becomes after DSEC. So with this, I conclude here. So to summarize, whenever you find that the entry chamber has some difficult scenarios like vitreous, synechia, the visibility is poor because of corneal haze, the patient is aphakic and you don't want to do multiple procedure in that patient, complicated cases, or the patient is having implants, glaucoma implants, or the patient have large iris defects, hypotonic, or there is coexisting procedure that you need to do, or in patient whom the medical or social reason that gives you only one chance, you have only one chance to take the patient to OR and do the procedure. So in all these cases it's better to go ahead with DSEC. And with this I'll conclude here. Thank you very much for your kind attention.
Situations, I agree with you that DMAC, although may not have that interface related issue, may not cause hyperopia, etc., but there are complicated scenarios wherein you can have a comparable outcome with an ultra thin DSEC, and that's what you emphasized on, and we completely agree. Since we are running short of time, we can move to the next speaker. So the next topic will be DMEC, and that will be presented by President Amrita Sharma.
Thank you, Rajesh, and thank you, Dr. Bhupesh, for making me a part of this important instruction course. I would be talking to you about the DMEC, the new warrior in the endothelial keratoplasty. There are no financial or proprietary interests, and DMEC is the most physiological graft because the diseased Descemet's membrane is replaced by the healthy Descemet's membrane. And of course, we all know the advantages of a sutureless graft. So it is indicated for cases of bullous keratopathy, Fuchs dystrophy, even failed PKPs, eye syndrome. Uh, Shared people are trying now, but not very many cases, and corneal decompensation due to any cause. Now, these are the cases which are suitable for DMEC, where the stroma is not hazy. And of course, these cases you can't do DMEC, but you have to do penetrating keratoplasty. Now, the visual rehabilitation after DMEC as opposed to DSEC is faster. It is only 1 month as opposed to DSEC, where it takes about 3 months. And this is the way we make do the donor dissection, in which the trypan blue staining of the Descemet's membrane is done, and the trypan blue is actually released from the Schwalbe's line or from the corneoscleral rim. And then, with the help of the McPherson forceps, one very gently peels off the Descemet's membrane, uh, and one has to be very careful while applying force here from all sides. So after it has been peeled again, it is laid over again in the same place, and then trephination is done, which is about 8 millimeters, or depending on the size of the white of the cornea. And then again, staining of this trypan blue is done. The peripheral part of the Descemet's membrane is removed, and this is already detached. So very carefully again, this is just elevated. The Descemet's membrane roll is just elevated, and then you have to. This is followed by. This was the time when we didn't use the S-shaped stamp, so the Descemet's membrane is just being removed like this here. Now, this is a case of Fuchs dystrophy with cataract, where the Descemet membrane scoring is being done. And after doing the Descemet's membrane scoring, which you can see on the intraopacity microscope, some of the remnants, if they remain, these can also be removed. This is the Descemet membrane roll which had previously been fashioned. This is placed in the injector. In this case, I'm using the IOL cartridge, which we normally use. However, now we've shifted to the glass cannula. So this is placed inside It is important that you suture because otherwise the graft will come out. The wound is then hydrated, and we look at the configuration which is present here. It is biceps curl downwards, so fluid is injected here so that the biceps curl is upwards like this, and then you shallow the AC. As you shallow the AC, the graft will uh, uh, become unfurl itself, and then air bubble is instilled so that the graft gets stuck to the back of the cornea. So this is the post-op picture. You can hardly make out that there is a graft which is present. Now this is the Descemet's membrane roll, which we now recently use with the S-shaped stamp. So we have IOCT, but we still like to use the S-shaped stamp. And the same procedure or the same steps are being followed, which were done, except that after you remove the flap, remove this Descemet's membrane onto one side, there is a dermatology punch which is taken, and you have to punch it so that you can put S-shaped stamp there. So this is laid again, and this is followed by this dermatology punch, which is about 3 millimeters, and an S-shaped mark is made on the bare Descemet's membrane, the stromal side up. So that is why S means the stromal side up. And this is then flipped back in position, and is again inverted, and the Descemet's membrane is already detached except for that little part very close to the S-shaped stamp, and then this is completely detached, and this is now floating in the uh, in the uh, in the BSS. Now in hazy corneas, it is possible to do it. Important thing is that you do the epithelial debridement, and then this is subsequently followed by the Descemet membrane remnants which are being removed, and the graft which is being injected. This is the cannula, the glass cannula that we use. And again, in this case, it is important that you look at the configuration of the roll here. It is a tight scroll, and as fluid is being injected, when it comes into this kind of a configuration, this is now a folded graft here. So this kind of a configuration, now it is biceps curl upwards. So you know that correct thing is up. Also, you can see the S, which is not clearly seen now. But once you put the air bubble, the S becomes visible, and also you can put a blob of viscoelastic so that it will be visible. So it does clear over a period of time. Now, this is just to show that this is extremely hazy cornea, and again the orientation of the graft is being deciphered with the help of the intraop OCT microscope, and it should be the correct configuration is the biceps curl upwards, and you can see that there is a very hazy S which also can be seen here. So S mark will confirm the orientation, and after this the air bubble is instilled. If you are beginning to do DMEC, the best way is that you use donors which are of at least 50 years plus, so that there's no problem in unfurling them. And then correct S stares at you, so you know that even though it is hazy, you are still okay to go ahead. Now you can, if you don't have a IOCT, you can also use a slit lamp orientation. This is the slit beam technique for DMEC graft orientation, and again the same thing you have to see, and that is the biceps curl upward configuration. So here we did have a slit beam plus we did have a IOCT. So this is just the same. Now this is a case where DMEC is being done for failed DSEC following failed penetrating keratoplasty. So we'd already done a DSEC, but when we started to do DMEC, we realized that some of the cases can get away even by doing DMEC, and there is an adhesion here which has caused the failure of the graft. And then I like to load it in the same configuration. That means biceps curl upwards. So this is the way that you see the biceps curl upwards. Load it in that configuration and inject it in that configuration. Put a suture, and this should be horizontal. And always these are the venting incisions here, and I like to make one here also, because otherwise that kind of chokes the graft at the anterior chamber. So you can just tap, tap, tap to unfurl it. And again, the S is in the correct direction, and all you have to do is just put an air bubble there. In ice syndrome also it helps. You can also do, and we've done a series of ice syndrome now with good results. Then this is just to show if you have folds which are there. Now in this case the desmetorexis is being done. The graft is taken in the Gabor cannula, and then this is injected inside. and then again tap, tap, tap to get it into the correct direction. This is the bimanual technique which is being used. And there is this resistant fold which is present over here. So an air bubble is instilled, but as you instill the air bubble, this fold doesn't unfold. So you have to put some saline above the fold, or some, sorry, BSS above the fold, so as to unfold it and then put air bubble so as to get the graft in the correct orientation and completely unfurled. Now, these are some of the cases which were done with DMEC, and the corneas look quite clear. You can hardly make out that DMEC is being done in these cases. They look as clear as just phaco, except for the wounds. If you see, the wounds are a little different, and they are a lot more than you would have in phaco. So this is graft rejection after DMEC, 15 months post-op. The patient complained of glare and there were some folds present. Topical steroids were given and this became okay. And again, the same case where rejection is there, the corneal thickness is increased, but after 4 weeks of topical steroids, the folds disappear and the compact stroma becomes compact. So DMEC results, if you see, the visual acuity is quite good, better than 6/9 in 85 to 90% of the cases. Stigmatism is less than 4 diopters. The graft rejection is much less. So if we compare it with penetrating keratoplasty, it is only 1%, because we are only doing a descemet membrane transplantation and not changing the whole of the cornea. Endothelial cell loss now is 25 to 30%. Detachments are important and you have to be vigilant. Detachments in DMEC are like a SOS management. You can't leave them, unlike DSEC where you can address them on the other day, because they have this zipper effect. So peripheral detachments, if they are present, you have to just go run and inject some air bubble there, because it detaches or unzips very fast. Then primary graft failure can be there, and of course there is no hyperopia. Now this was about PDEC, but I think this is not a part of the this, so I will not be talking about it. So this is just to compare the other modalities of the endothelial cell loss with other modalities of corneal transplantation as well as the graft rejection. And thank you very much for your kind attention.
Thank you, ma'am. Thank you so much for this wonderful talk. Any questions? I think time is up and next session will have to start. Thank you, everyone. Thank you for joining the course.